So are you recommending organs to your patients? What about liver, heart, kidney, or even things like uterus and ovaries that we can now get in desiccated organ supplements?
Yeah. So I don't talk to my patients about always eating organs, but I have a lot of patients that ask about it, especially like in pregnancy. And I think it's a great way to add nutrients to your diet, right? When you're adding liver and heart and things like that. Obviously, a lot of people are averse to like the idea or the taste or like it's weird. So it's great that we have desiccated, organ supplements that we can use. The hard part is like with most supplementation, we know like the content of what's in there. And with the desiccated organs, it's not as easy when you're saying like, oh, you need this many milligrams of, folate in pregnancy or whatever. But I think it's a great way to add nutrients to the diet. I myself do beef organs and liver, pretty regularly. So, and I have a MTHFR and I have to watch my homocysteine. And what's funny is if I stop the liver, my homocysteine will go up.
How high does it go?
Um, I've had it, let's see, my last one, it was over 20. And then my most recent one, I got it back down to 9. So, but
Just with liver. Amazing. How much liver are you eating?
so I do, I actually have some in the freezer right now. My patient just gave me a new recipe for this pate I'm going to try, but I mean, I mostly do desiccated. So I do, 6 capsules per day usually, but I mean, I think 1 to 2 ounces just even a week is great.
And will affect things positively for people.
Yeah.
Any concerns about moderate amounts of liver for women in pregnancy or anything like that?
Yeah, I mean, I do think you can eat too much. I mean, when we look at toxicity, of vitamin A and things like that, it's with supplementation with synthetic forms. But I mean, I do think like anything, you can eat too much. So I think that a couple ounces, a few times a week at most is perfectly fine. You're going to get, good levels of the nutrients that you're trying to get. But I think you can overeat it. I mean, I do. Well, we don't have studies to show that, but
Yeah, and I agree with you that retinol palmitate is the form that's in liver, and retinol palmitate is in many supplements. There's also retinol acetate, which is a water soluble form of vitamin A, much more likely to result in toxicity. But if we're looking at the fat soluble forms, retinol palmitate in liver, retinol palmitate in a supplement are probably pretty equivalent. And there seems to be a pretty reasonable safe zone for people. And if you eat massive amounts of liver from a cow, you could probably accumulate too much. And if you eat a polar bear liver or other carnivorous animals' livers, you might be able to accumulate too much. But I think that my position continues to be that moderate amounts of liver, a few ounces a week is totally fine and safe. The desiccated supplements are nice because they don't have a ton of liver, but they have enough to provide nutrients. Folate and riboflavin that we know are important for people with MTHFR polymorphisms and other biochemistry in all of us. I also have an MTHFR polymorphism, but you're not really at danger of getting anything, getting too much at all. Now, would you want to go out and eat polar bear liver or seal liver? Probably not. And I kind of feel like, I guess this is just the way this type of discussion happens. There's been discussion about this, and there's even people who believe that vitamin A is toxic. And I think you're going to have to make a really strong case to even believe that something that's literally in a lot of different foods is actually toxic. Like humans never ate an egg yolk. Evolutionarily, humans never ate liver. When I was with the Hadza, they literally treated the liver like it was made of gold. They were just so careful with it and put it on and they distributed it. But, there's a tribe here of 50 people and all the men are going to get the liver. And so they're all going to get maybe an ounce or half an ounce when they kill an animal. And that's a big animal's liver. So small amounts seem completely healthful. And I'm not convinced at all that vitamin A is in any way toxic for humans. It's just that it has a dose response curve. And like anything, too much can be harmful. So we should eat evolutionarily consistent amounts of liver for all the benefits that we enumerated, especially in pregnancy, probably, right?
Yeah, for sure. I would say most of my patients, it's funny, even my very carnivore patients in the first trimester have horrible food aversions, especially sometimes to organ and meat. But, and I don't know, I like want to figure out nature's reason for that, but I haven't really been able to put a finger on it. But no, I have no issue with my patients, adding organs. And I actually have some patients who have made the, personal decision to stop thyroid replacement and just do desiccated beef thyroid. And I followed their levels and they've done pretty well.
What do you do when your patients have aversions, food aversions? Because I've heard about this in some of my friends and I think, wow, like that's got to be challenging. How do you walk them through that? Like if you're oftentimes they do get aversions to meat. Like, what do you have them do in that situation?
Well, I mean, when a patient gets pregnant, there's about a immediate 30% increase in, basal insulin production, but the insulin sensitivity in the first trimester is actually pretty good. So a lot of times they have to eat more whole food carbohydrates, and that's fine. I mean, the first trimester, if you've obviously never been pregnant, Paul, I mean, it's like survival. It's like, it's hard. It's really hard. Just the nausea, the fatigue. I mean, you got this tiny little, embryo, and it's like sucking the life out of you. But I mean, you want to make sure they're not losing weight. So we watch their weight. You want to make sure they're not getting metabolic derangements like loss of electrolytes and things like that if they're, actually vomiting. But, sometimes we have to supplement with, with whey proteins and things like that just to make sure they're getting, enough nourishment. And that's where, prenatal vitamins and things like that can be helpful, because it's like an insurance policy. If you have somebody that can't eat, at all, that they're at least getting, something, or maybe they can take some, organ supplements or something like that. But it's hard. It's really hard. And sometimes they need medication to control the nausea. And usually once they get into the second trimester, the energy comes back, the food aversions go away, and they can eat steak again. But it can be survival. It's hard.
That beginning part. Yeah. You're right. I've never been pregnant, but looks difficult from where I'm standing. All right, let's talk about perimenopause and menopausal transition. We spoke about this a little bit on the last podcast, but women's hormones are going to change a lot with menopause. Like, what do you do for those women, and how do you help them with the transition?
So when I was talking earlier about estrogen dominance, remember I said that a female is born with all the eggs they'll ever have in their lifetime. And what perimenopause is that we're getting very low on our stores of these little follicles. So the brain's like, hey, 20 of you get ready to go to the party, and only 2 people show up. So we're running out of follicles, and there's going to be months where we're not ovulating. And so when we look at estrogen and hormone levels during perimenopause, they're quite what I call psychotic. One month it's 200, next month it's 40, then it's 150, then it's 70. So it's all over the map. It's up and down and up and down and up and down. But if we look at a general trend month to month, year to year, during these perimenopausal years, we see a gradual decline in estrogen production. So the estrogen is going really low. The progesterone is not being released because you actually have to ovulate to make the progesterone. So we're seeing a relative state of estrogen dominance. So once again, they might have low levels of estrogen, but they have no progesterone. So it's kind of this relative state of estrogen dominance. And then once they go through menopause, the clinical definition is no periods for 12 months. You can essentially be assured that they're menopausal once they hit that benchmark. They make very small amounts of estrogen, usually less than 23. On a lab value, there's no progesterone, and they're menopausal. Now, some people will make this transition just fine. They won't have any symptoms at all. I find that women who take care of themselves when it comes to nutrition and movement and sleep and stress reduction tend to make this transition very well, but some women can be super symptomatic. So as we lose the estrogen, we start to see hot flashes, night sweats, they get brain fog. Because of the lack of progesterone, they develop anxiety. They can get depression. Their sex drive goes down. They get vaginal dryness because of the loss of estrogen. And then the things that they can't see and feel, increased rates of osteopenia, osteoporosis, increased risk of cardiovascular disease, because estrogen is actually really good for insulin sensitivity. So as we lose the estrogen, we become more insulin resistant. We start depositing fat around the organs called visceral fat. And then our risk of cardiovascular disease starts to go up. And if they're eating a horrible diet and tons of, abuse of seed oils and sugar and carbs and things like that, then that's when we really start to see their risk, really start to skyrocket. I'm a huge fan of hormone replacement therapy. It really got a bad rap for a long time. And now we're kind of seeing the pendulum swing. Vaginal estrogen therapy is extremely safe, even for patients with a history of breast cancer. So I think all women should consider vaginal estrogen therapy in the perimenopausal and menopausal transition. It's amazing in women's health, the atrocity. Like if a man's penis like shriveled up after andropause, I can assure you like every man would be slathering estrogen on. But for women, it's not offered all the time. Doctors don't ask about it. Women are afraid to talk about it. And so I'm a huge fan of hormone replacement therapy. It's better at prevention than it is at reversal. So once you go through menopause, there seems to be kind of this perfect window of opportunity really within 10 years of menopause that you get the biggest benefit when it comes to hormone replacement therapy, not just for hot flashes and night sweats, but for reduction in risk of dementia, Alzheimer's, osteoporosis, cardiovascular disease. But if you wait till you're 60 or 70 and then you want to go on hormones, it's not as good at reversal. So it may make your symptoms like hot flashes and night sweats better. But the truth of the matter is that there's no way to turn the ovaries back on. So, I mean, once you go through menopause, you're in menopause. Hormones aren't like a pharmaceutical drug. A lot of people are like, they lump it in like with statins, like, oh, my doctor's just pushing hormones on me or whatever. Like, they're really more of a performance enhancing drug in a way. I mean, it's not for everybody. There's certainly patients that shouldn't take hormones or, would choose not to, but I'm a huge fan of it. It can really improve the quality of life for a lot of people. And like I said, it can help with risk reduction of things that are likely to make your life miserable, like dementia and Alzheimer's. There was a really cool study just in the last 2 years showing that women who did estrogen replacement therapy had decreased rates of Alzheimer's and dementia.